Hi, Terri. Welcome. Thanks so much for joining me on this week's episode.
I'm so happy to be here. Thanks for speaking with me. I've
Yeah,
been looking forward to it for a while, and I've been following you for years, so I'm super excited to be able to speak with you.
awesome. Yeah, I'm really glad you reached out to share. And the first thing that jumped out to me was the crotch crusader. I think that's one of the best lines I've heard in a while. So, can you tell us how you became a crotch crusader?
Sure, like where the actual name came from, or like my journey to
Yeah,
crusade.
kind of your journey and then how the name came along will be part of that story. So, how you came to be where you are now.
Sure. So, I'm a physical therapist. I've been practicing for 8 years. I was a massage therapist, yoga teacher, Pilates teacher before that, and I always had an interest in pelvic health, although I didn't know that I was necessarily going to go this route. But I was actually in an oncology specialty center and doing oncology care in outpatient and got really interested in pelvic health. And so I've been practicing pelvic health for 5 years now. And when I found the specialty, it was like, oh, this is it. This is my jam. And the name Crotch Crusader, I think I heard it in a Susie Gronsky podcast. I think she came up with it. So I will credit her.
That's
Yeah.
awesome. Yeah, it's I love it. I think it's great. So I know the hashtag pelvic mafia was used for quite a while on social media, sort of back in the I say the early days of when social media and pelvic health was starting to be talked about. I don't see it used quite as much, but I think Crotch Crusader could also have another good hashtag. We could start another following.
Hashtagging it. You're right. I have it in my Instagram bio. I'll start hashtagging it. Thank you. Thank
Yes.
you for
Yeah.
the nudge.
Yeah, totally. Cool. So I want to start with a big part of your practice, which is prolapse. And I would argue most pelvic health physical therapists will have obviously a lot to do with prolapse. That's one of the more common pelvic floor conditions. But can you talk about what prolapse is and what are the most common types that you see in your practice, or maybe even what does the research say are the more common types?
Oh, that's a big that's a big one.
Question to start with.
Yeah, that's okay. I'll break it down. But so I definitely got interested in it early on. Pelvic health was a kind of a passion for me specifically because of my own experience, if I might share, with being newly postpartum, newly in the specialty, and being diagnosed with my own prolapse. I was only 7 or 8 weeks postpartum. I was very new. I came into the clinic just for, I didn't have any symptoms, just for regular, postnatal rehab. And she gave me a handout with all the things I was never supposed to do again: run, jump, lift, squat with my hips below my knees. And I was devastated. And I thought it was a death sentence, to not to mince words, really. And it really put me on a path to want to know everything that I could about it. And it's been quite a journey to get to where I am now, reading every piece of literature I could find, taking every course that I could find. And I absolutely love helping people because it is so common. And you asked me what it is to begin with. I didn't
Yeah.
even define it yet. But essentially, it is the pelvic organs, for pelvic organ prolapse specifically, the pelvic organs pressing into and sometimes coming out of the vagina. So there is rectal prolapse, which is a different things. But for pelvic organ prolapse, POP, which is usually shortened to prolapse, specifically usually refers to a vaginal prolapse. So there's an anatomic definition and there's a clinical definition, and there really is a difference that I like to share with people because there are essentially 4 different stages, and stage 1 and 2 are considered more mild. Stage 1 now, which is basically just a slight bit of organ descent. And if I can show on my little model here, so I have a little crochet model. So it can be coming from the top down, the bladder prolapsing. It can be the rectovaginal wall, the wall between the rectum and the vagina, that's kind of pushing in. And it can be coming from the top down, either the apex of the vagina, or if the uterus is present, then you can also have a uterine prolapse. But it's essentially considered an apical prolapse, or something coming down from the ceiling, basically, you can think of.
Right.
So the milder stage 1 prolapse now is considered normal. It has been kind of classified, and the new definition that's actually just recently come out last year, the new clinical definition of prolapse, the descent needs to be at least to the vaginal opening or beyond to be considered a clinical definition of prolapse. So someone might have an anatomic descent. They might have stage 1 so stage 2 is 1 centimeter. The prolapse is coming to within 1 centimeter of the opening or 1 centimeter beyond. So stage 2 can be either within or outside. And so some people do break that down into like 2A and 2B, but not to get too, lost in the weeds. Essentially, the reason why that definition has changed is because over the years, we've gathered so much research and found that a great majority of women, even young women, even women who are nulliparous, who have never had a baby, 50% have at least stage 1 prolapse. And so the urogynecological community finally has kind of shifted things after many years of kind of grappling with this definition, and has kind of redefined that mild prolapse is normal, or at least acceptable amount of support. And having that mild prolapse does not necessarily mean that it will progress. It doesn't mean that you are at any more risk of having a worse prolapse than someone who has no prolapse at all.
Okay.
I know
yeah, well, and before we go into, because I had also asked about common types, but before we go there, I want to expand on that a little, because this is new for me as well. So I've always, at least in North America, as you said, there's 4 stages. Early stage was sort of just, as you say, just a partial bulge, sometimes very often asymptomatic. Stage 2, I used to be that it was 2 centimeters away from the opening. Stage 3 was at the opening. Stage 4 was out the opening. So that's kind of what it used to be, at least from the people that I've been taught by and led by. So that now has changed, if I understand correctly. Stage 1 is kind of considered just, many people have it. Stage 2, 1 centimeter above or below. So you could technically have a bulge slightly outside the entrance in a stage 2. Is that right?
Yes.
Interesting.
And that's and there are different staging criteria. There's the Baden-Walker scale, but for the POP-Q scale, that's what the criteria is. And then
what would stage 3 and 4 be then?
So stage 3 is from 1 centimeter beyond the opening to within, so you have to check the total vaginal length, and then basically it's anything from within 2 centimeters of what that total eversion would be. And then stage 4 is complete eversion.
Got it. Okay. And you mentioned the how, I guess I just asked the question, how is it graded? So when you go in, what sort of, do you have is there a tool that is used? Is it manual palpation? Are we referring to, you mentioned a scale?
A scale just meaning a system of measurement, not necessarily a tool, but it's measured with observation and with the person who is being examined bearing down fully for 6 to 8 seconds. You can either use a half speculum, but there's a way that we kind of screen it in pelvic physio quite often, just with a gloved finger, and we press.
For those of you who are listening, if you head over to YouTube, you'll be able to see the video where there is some demonstration.
So you press up and you have the individual bear down as much as they can. And then if you see things descend, either, however much they descend, and then you can also press the tissues down this way. And then you can palpate deeply and feel either the cervix or if it's not present, the apex of the vagina. And then you can measure how much it descends. There are sticks that you can get. They're called POP-Q sticks that have little centimeter measurements on them. And that's how you measure the maximum descent of.
Right.
Yeah.
And the POP-Q is essentially, as you meant, sort of the grading scale that is used to evaluate. Is that correct?
So it's not as much of a grading scale. There is the stages that they use. They use the staging words for the POP-Q.
Okay.
And that is really when they came up with that in I believe it was 1996. They used expert opinion because they didn't have any data to kind of come up with that. And, for deciding what was stage 1, what was stage 2. And really it's you measure and it goes on a grid, and it's how, surgeons will do pre-op and post-op to basically describe what the anatomy is and how much it descends with bearing down.
Okay. And just for those that were listening, if you can't see the video, the first one you were talking about, you were putting your finger in, you as the clinician putting the finger in and pressing against sort of the anterior or the front wall of the vagina to see the uterus and to see the back wall. And then you also pressed on the back wall and would look in and see what's happening on the front wall with the uterus and with the uterus. Is that correct?
Right.
Is that right?
That's how it tends to be done in pelvic physio. And quite often now, more so, a half speculum is being used. You can also use like a tongue depressor that's like wrapped in a glove and kind of use that to compress the tissues up and down as you see what's going on to give you a better view. Yeah.
Okay. So with this information then, with this kind of new classification, something that I recommend is that people see a pelvic floor physical therapist once a year as a check-in. Yeah. And part of that purpose, I think there's value in knowing if there is something we need to kind of monitor or manage or what have you. So, and this is mainly the reason, if there's early stage prolapse, I personally would want to know that because I would want to be able to come in and do whatever intervention strategies I need to prevent that from getting worse. I've also heard on the flip side, more so for people who've been working maybe with a medical provider who haven't been told, because a lot of people also don't want to provide that information because they think it might alarm the patient or create issue. So I can see the logic on both sides. Mm-hmm. Where do you sit in that field? What would you recommend?
That's a really good question. So for one, I do think that it's important to ask people when they come in what sorts of evaluations they want, whether or not they want to be screened for organ descent, what it might mean if we find something, because we know symptoms and anatomy don't always match up, right? So, I think most people want as much information. That's why they're coming in. But I think there is really powerful how information is presented. So I think that's a big part of why there has been the shift in the clinical diagnosis of prolapse, because those with stage 1, per the POP-Q, stage 1 organ descent, it's not known to be progressive. And so essentially it is really redefining as normal. That doesn't mean that if someone comes in and they have stage 1 prolapse and they're symptomatic, that we're going to say, nope, you're normal, you don't need to do anything, shoo them out the door and completely disregard them. Absolutely not. We still look at their symptoms. We look at other drivers for what's going on, and certainly help them and screen them for things that are meaningful, in my opinion. So I don't think that finding stage 1 prolapse that's asymptomatic on evaluation is necessarily something that needs to be alarm the patient about. I would definitely tell them, I'm seeing, this amount of movement. This is considered to be within the normal realm. But there are some other tests and measures that I do that I think are more impactful, that do show the risk of potentially having some issues in the future, how pressure is being managed, some other measurements that we take called GH plus PB, which is a part of the POPQ measurement system. And those measurements do actually give us a lot of information for, one, whether or not someone might be more symptomatic or whether or not they have a higher risk for developing or worsening prolapse in the future.
Right.
So I tell people what I find. I try to offer it in a non-pathologizing way. I definitely don't give that handout. I created actually a different handout that I'm happy to share with you and anyone that might want it, that has more evidence-based information.
I want to come back to your story, but I'm going to ask one more thing before we go there. And you mentioned GH plus PB. Can you talk about what that measurement is? Because it does get referred to a lot, especially with prolapse and increased risks, depending on what your score, is that the right word to use there, would be on that?
Yeah, what the measurement is. So I have all this stuff here and can I grab one very quickly?
Yes,
okay.
Please.
So here are the little POPQ sticks. GH refers to genital hiatus, and what that means is the opening of the most superficial muscles. PB is perineal body. The measurement of GH plus PB together is basically the levator hiatus, or the opening in the deeper pelvic floor muscles. So both measurements are important for different things. And the way that we measure is very simply, we hold up the POPQ stick, we measure from the urethral opening to the base of the vaginal opening, and from the base of that's for the GH, or these superficial pelvic floor muscles, basically. And then perineal body is from the base of the vaginal opening to the anus, basically the center of the anus. We measure at rest. We have the patient bear down maximally. And then looking at those measurements, there's all kinds of research on what numbers are considered to be higher risk for both symptoms and risk of developing prolapse in the future.
Great. Thanks for explaining that. So coming back to your story, you went in just because you were told or you believed that you should have an assessment postpartum, and you didn't have any symptoms. And then you were given a brochure that had all of these limitations that you should never be able to do. I'm assuming because they found a prolapse, correct?
Correct. Yep.
Yeah. And that then sort of sets off.
Grade 1. It was grade 1 to 2. She kind of gave me, she wasn't sure. And I did go for, I think 7 months later, to a urogynecologist to get a pessary fit. And she's like, there's no prolapse. There's nothing. So it is, there is no data. I would love to have more research on that early postnatal period and how much, because there's so much more tissue extensibility. I mean, I had a vaginal delivery. There's a lot going on. And the fact that stage 1, we know, is, now considered to be a normal or at least
acceptable range
amount of organ support, then, really have we been pathologizing women with mild prolapse for so long, restricting them, telling them don't lift weights, don't go, do all these things that you need to do. But guess what? We need to actually do these things. We need to lift strollers. We need to lift. I mean, I was thinking like, I have this, 10-pound baby now in a 25-pound car seat. and he's going to only get bigger. So what does that mean? But anyway, just, these limitations and restrictions are really well intentioned. They're meant to help save people from this thing. But restricting people from activity, I think just makes us weaker. It makes our tissues more susceptible to damage. And so, the irony is so painful because, people go out, they don't exercise, they don't do all these things, and then they have to go, move something one day, and then they feel, then they have a symptomatic organ descent after that. And, it can become kind of a self-fulfilling prophecy.
Right.
Yeah.
Yeah. And it's interesting too, because as I myself personally am postmenopause and work with a lot of people in that sort of perimenopause, postmenopause transition, and becoming more aware of the vasomotor piece, the bone health piece, the muscle loss piece, postmenopause. And I just think of all the people who have been either told to restrict, not lift, not do impact, not this, or who have kind of self-prescribed them those restrictions because self-prescribed to themselves because they were afraid of leaking or because they were afraid of making their prolapse worse or didn't like the symptoms or whatever reason. It further compounds the already increased risk we have, especially moving into that phase of our life.
Right, absolutely. I mean, we know the benefits of exercise are well established. Right. Like you said, the bone health, the heart health, the mental health. And, you have to weigh all the risks and benefits. And that's certainly what I talk to people about, depending on, what they want to do. It's most of the people that come in just want to be able to kind of like go about their lives. But I do have people who are higher level who want to be, lift heavier weights, who want to be able to run and things like that. And, we don't have a lot of really good longitudinal data, or we don't have good long-term studies on the impacts to running per se. But what we do have is a lot of good research on intra-abdominal pressure. And basically what a lot of these studies show is that there are no completely safe or unsafe activities. And the way that someone does something, even between, even the same person doing the same movement, it can be different, depending on how they do it. So that is really what's important, not necessarily these blanket, recommendations.
Yeah. I reflect back to when I was first starting out, and at the time there was really not a lot of fitness professionals in this field. And I was working and kind of collaborating with pelvic health physios, and we didn't have a ton of research at the time. And the general consensus at the time was there was a good and a bad list of exercises, and, no twists, no planks, no crunches, no this, no heavy lifting, no jumping. And so when I think back to when I was first getting this word out there, it was very much like the brochure you had, very restrictive. And then forming a second business with two other women, one was a pelvic health physio, one was a trainer like myself, and the three of us would have very healthy debates about crunches or not, and rolling to your side and not. And I always seemed to be the one who was saying, but it just doesn't make sense that we should, just because we've given birth or just because we're doing this or just because we're older, that we should not be able to do a forward flexion movement in our life anymore. That doesn't, so why are we not kind of training for the resilience in that movement? And so anyway, it was always that dance. And then Anthony Lowe was a really big catalyst for shifting that conversation, which I'm forever grateful for and still is. And so that was, I think, a kind of a turning point within the last 5 to 7-ish years of opening up that conversation of we absolutely can and we absolutely should be doing all of these quote unquote unsafe exercises that we were told along the way, right?
Yeah, absolutely. So, I mean, we definitely, I think, a lot of that early advice came from a really good place, meant to be protective, but it was restrictive, and I think it has had negative unintended consequences. And, we don't necessarily go completely the other direction, although there are some people who
Yeah.
definitely, want to say, no, you can do whatever you want. And really it's up to the individual to decide risk versus benefit. But I think with progressive loading, you can get to very safely lift weights that can strengthen your muscles, strengthen your bones, have all the and even some impact activity with the right, support, especially with the right training, with being progressive, can be an incredible tool for people.
Yeah, yeah, I wholeheartedly agree. So I had asked earlier, and it's not that relevant, but it kind of is, just out of curiosity. What are the most common types of prolapse that you see in your practice?
In my practice, I tend to see a lot of anterior vaginal wall descent. Some people call it cystocele, which is the bladder descending. And I'm not sure if I've just had a lot of those lately, but it
Hmm.
seems to be the most common. Although certainly, I think that as far as rates in the general population, I haven't seen one being necessarily more than another. I think
Yeah,
they
yeah,
happen equally, and quite commonly, there may be descent in all three compartments.
right.
Quite commonly, especially when there's descent of either the uterus or the top of the vagina when the uterus isn't present, it kind of pulls things with it.
Right.
So, yeah,
Yeah.
these are kind of
And yeah, so in terms of the treatment, I really want to go, like, no pun intended, heavier into the lifting and the impact. But before we do, when you have somebody who is symptomatic, who is potentially looking and wants to do the higher impact activity, wants to eliminate symptoms, what sort of treatment? So we talked about pessaries. That's one thing that I want to explore. Where do you start? Is a pessary the first thing, or are there other things that you explore first?
certainly. I mean, the first thing is just educating people on generally what they can do for symptom management, how to, do elevated hips pose, legs up the wall, really start with the basics, help them learn how to navigate their own symptoms. So it could be that they're more symptomatic at the end of the day, taking breaks throughout the day. So a lot of kind of lifestyle advice and education. Certainly, constipation management is a huge one to prevent the bearing down, just to keep everything moving. Talking to people about how they're going to the bathroom is a big one. And then, checking out, what's going on with their pelvic floor muscles as far as strength, coordination. Do they have an automatic contraction with a cough? And if not, kind of trying to retrain that so they can learn how to better support their organs. But pessaries are a big part of the treatment. But we certainly also look at hormonal health. We may recommend that they seek care to get some topical estrogen or other topicals that may help. And that certainly can be a big driver of symptoms when there is a very mild prolapse. So the health of the mucosa is really, really important, especially if you're going to bring on any kind of device like a pessary. Definitely
Right.
needs to have good tissue health. So, and then we gradually will work towards, looking at what's happening in standing, look at what's happening with exercise, pelvic floor muscle training, definitely, but whether or not that has as much of an impact as all the other things put together,
Right.
um, yeah.
Yeah. Okay. And so let's talk then about pessaries. And there's many different sizes and shapes. And you, as a physio, fit pessaries, which is not yet globally accepted. A lot of times it may be a urogynecologist or nurse continence advisor who is fitting the pessaries. What I like about the fact that I absolutely believe that all physios should be able to fit, because I think it will eliminate a lot of the weight and a lot of the frustration that is currently associated with finding that right size and shape. So where do you start with the pessary conversation.
Sure. So a pessary is an internal device. The way that I describe it to people, to clients, is it is a kind of like an orthotic that you would put in your shoe, but it's worn vaginally. I also like to say sports bra for your pelvic organs is a nice one. And they are medical grade silicone devices. There are lots of different shapes and sizes. So I will recommend them. Basically, anyone can get a pessary who stage 1 to stage 4. There are definitely certain factors that can contribute to a more successful pessary fit and a less successful fit. And I can talk about that more in a moment. But I'd love to show you some different, I have a bunch right here if you'd like to see different types. So this is the ring. This is the most common type. And the ring can really be used for all compartments, but it tends to be more so for a milder stage 1, stage 2. It tends to work a little bit better for anterior vaginal wall, just because of the way the organs sit. And so if I can show, I'm going to pull off my superficial. So we would fold it in half.
So it's sort of like it's like a skinny donut that you would fold in half like a taco, basically.
Right. Fold it like a taco, little bit of lube, insert, and it sits up on top of the pelvic floor muscles. Mm-hmm. And so if someone does have like a muscle injury, a wider levator hiatus, and so that's where that GH plus PB measurement comes in, that corresponds to a wider measurement. Someone may not be as good of a fit for the ring. But typically it is the first one that's tried. I think around 70% or something are able to be fit successfully with a ring. So it's the softest one, it's the easiest one on the mucosa, and it can stay in for like 4 months. Some people may even leave it in longer depending, but this one does not have to be self-managed. So this is really a better one if someone like doesn't want to have to deal with anything. It can stay in. You technically could even have intercourse with it in. Many people choose not to. So I do like to teach people to take theirs out if they can.
Right.
The next most common probably is the cube. And so the cube has suction on 6 sides, and this can be used for basically any stage or any grade, but it has to be self-managed. It cannot be left in during intercourse. Most recommend to remove nightly, although hopefully we can get more data, but one of the big educators for pessary fittings, she thinks that it's the in and the out every night that can be a little abrasive to tissues. And so there, in some, are recommendations just to take it out a few times a week. We really need better data for those types of recommendations. But some people wear these even just for exercise. They'll put it in for exercise, remove it. But you do have to take care with removing them because you have to break the suction on all sides. You can't just pull straight down from the string.
And are you referring to Gaynor Morgan?
Gaynor recommends, I have taken her course. She's not who I'm speaking about. She recommends nightly. That's what the manufacturers recommend.
Yep. Yeah, Gaynor I interviewed on the podcast as well too, so I'll link to that. Yeah, I love Gaynor. So there'll be links to hers as well, so it goes a little bit more depth into pessaries. But yeah, cool. Carry on.
Hers right here that she invented actually. Yeah.
Yeah, awesome.
She's fantastic. And then also have the Gellhorn, and this one is in its packaging, but this one has suction on the top. And it sits in, this one is, you can use it for different types, but it's really great for uterine prolapse and Then there are also certain types of pessaries that are really more for urinary incontinence. Can I show you a few of those as well?
Please.
They don't work, they're not quite as effective. Um, just because I'll show you this little knob, which you place it, where's my pelvis? You place it, insert it, and you have to kind of get it rotated around so that the knob is, there you go, so that the knob is hitting the urethra. And so when it rotates and the knob slips off of the urethra, then there can be kind of leaking again. But there are some over-the-counter, at least in the States. I don't know if you guys have these in Canada, but we have the Impressa and the Revive, which are over-the-counter. This is the Impressa. It's single use. It goes in, expands, pushes on the sides of the vaginal walls, pushes on the urethra, which helps support the urethra. And then the Revive, if you'd like me to show that as well. And this one is a multi-use, has a little applicator, as well as the Impressa has an applicator. And you press it, it expands vaginally. It's quite a different different shape than the Impressa, and this is what supports the urethra. And then it just can be pulled out with the string, placed back in the applicator, washed, of course, placed back in the applicator, and this is just used as needed. So I quite often will suggest to people to try the over-the-counter ones just to see how they feel about having something there, to get a little bit of confidence with manipulating a vaginal tool, and especially if someone has associated urinary incontinence. But most people, I feel, are much more open to the pessaries now than there used to be. I think because people are realizing that surgeries are not are wonderful for some. Not everyone wants one, and certainly it's good to even try a pessary before you do surgery. And there's one really, really important reason that I've seen sometimes postoperatively. People come in following a prolapse surgery and they are leaking like they never had before, because it uncovers this occult stress urinary incontinence that they didn't know they had, because the urethra was being kinked by the prolapse coming down. Organs are put back into place and then they're leaking. And once you've had surgery, depending on the type of surgery, it may not be a good idea to use a pessary if there's mesh there.
Yeah, that's such an important point. I love that. And the poise you can get in Canada. The Revive, I've had a few people who have been able to order it through Amazon into Canada as well too. So exactly as you said, I do recommend that people at least give that a try. It's an inexpensive way to see, and there's also a lot of cool innovation that's happening in the pessary world. So 3D printing and imaging that will be specific to your anatomy. I think there's some interesting things coming along the way.
Yeah, and there's a couple of over-the-counter products that are coming out as well that are meant for organ support, not just for urinary incontinence. There's some great things coming out, and if I say nothing else about pessaries, I do want people to know that they're not just for symptom management. They can help remodel the architecture with consistent use. The GH or the genital hiatus can really come in because it lifts the pelvic organs off of the pelvic floor. Pelvic floor can function more effectively. You can work on your strength and all of that, but tissues, ligaments, fascia can shorten, can remodel, and many people need either a smaller or a different type of pessary when they come back, and people often, after many years, may not even need a pessary.
I'm so glad you said that, because I hear from so many people that they're concern with using a pessary is that it's a crutch and that they're going to become reliant or dependent on it. And exactly as you said, it really can actually improve the function and benefit. It helps improve some of your symptoms as well. But I love the way that you explained that. It's so important.
Great. Yeah. And people are concerned about that. And, one of the other metaphors that I really like to use is when people have issues with eyesight, we have different choices. You can wear glasses, which is like an external support. Like there's shorts that that are made for helping kind of support things. Or you can wear contacts, which is like the pessary, or you can get the LASIK surgery, and often you might want to try the glasses and the contacts before you go to the LASIK.
Totally. That's such a good analogy.
And
so
sometimes you have the LASIK and then you still need to wear the glasses, right?
Yes.
Yeah.
So when you're fitting, then you start out typically with a ring. And as you mentioned, that's the one that is fairly likely to be successful. If it wasn't, could you know that within that first session? So when you go to your gynecologist, oftentimes people don't have as much time. When they see a pelvic floor physical therapist, they typically have longer treatment sessions or longer appointment times. So could you theoretically, if needed, put one in and know fairly quickly if that was going to be the right one or not, and then potentially try another one?
Sure. Yes, absolutely. So I have, multiple sizes of each pessary. I have, I only keep the top, 3 that I would use four, that really will fit like 95% of individuals. And if I need a specialty one, I'll order it. But for the most part, yes, we have a lot more time. We see people more frequently too. So if someone is coming in and they've got, a couple of weeks scheduled, we can tweak things. But the way that we check to make sure we do a fit, and there's different ways to fit for different pessaries depending on what's going on. And we have an idea of what size. We'll put that size pessary in, and then we'll have the person stand up, do a bunch of jumps. I have a bunch of heavy weights. They'll lift some heavy weights. They'll go void their bladder, make sure that they can void, see if they can feel it. I'll also have them reach and feel, and often they can feel kind of where the pessary is coming down, and I'll have them just, especially in the first couple of weeks, they want to go and kind of just push things up, even if they feel it coming down. And then after a few weeks, typically, even just a few weeks, things can kind of start supporting a little bit better. So, certainly, if it's continuing to be expelled, then we would want to try something probably with suction, like the ring or the Gellhorn. But I'm sorry, the cube or the Gellhorn have the suction.
Right.
But I just find the ring is so much easier for people to put in to take out. There are sometimes, though, if someone does have a very wide levator hiatus or they have a very short total vaginal length, if they've had a hysterectomy that where the cervix was not spared, or they've had a previous surgery, then they're probably not going to be a good candidate for the ring. So there are some things that we would look at and think about where we might not try a ring to begin with. But it is so great that, people are coming in more often. We have more time with them. And I do think that that's one of the reasons why, physios are really well suited to offer this in clinic. Yeah.
1,000%. So I want to shift over and sort of end our conversation on the weightlifting and impact activity. You and I are on the same page. Let's build the tolerance, the progressive loading. That's one of the principles of fitness is progressive loading. So you've got weights in your office and pessaries. We can do it sometimes with or without pessaries. So how do you help people get that confidence? So people may be coming to you who have been told that they can't do this, can't do this, can't do this, or maybe they don't have that knowledge, but they do want to be able to run or lift or, not be limited in their activity. So how do you get them there?
So, good question. It depends on the person, where they are, where they want to get to. And then, of course, what we find in the evaluation, really give them the information to help them weigh the risk and benefit. but building people progressive programs. You know, for instance, I had a woman who came in recently with a new prolapse. She's menopausal. She hiked like 2,000 miles last year. She hiked like the PCT. I mean, this woman is very, very fit. And, you know, her prolapse happened while she was on a hike. So can we say that her prolapse happened because she was hiking all those miles? We can't. She built progressively up to that. There are other things, you know, that were happening for her. And she is, I just fit her last week with the pessary, but even before she had her pessary, she was already back up to walking. I think she was hiked, maybe did a 12-mile hike, and she was managing her symptoms with when she would feel the bulge. Now, hers was grade or stage 3, but it didn't always sit out. She was mostly, you know, fairly reasonable as far as her symptoms went. But she was able to really manage her symptoms without the pessary. But she wanted to go ahead and get the pessary so she could have that support because she's about to hit the Appalachian Trail and be out for weeks and weeks at a time. And she knows that she'll have her ring in and she won't have to worry about it, taking it in and out every night. So that was, you know, another thing for her, why we chose that one. So the cube might not have been as good for her taking it in and out, which she's like in the woods.
Yeah.
As far as exercise, you know, I helped guide her back to 12-mile hikes because she was already doing 20-mile hikes. But someone else, I might, you know, give them a program that was, went out a little bit further and was really gradual. And then, you know, with weightlifting, I often will assess in standing, see what's happening with, you know, pressure management, see what's happening with pelvic floor strength, coordination, and then gradually build from there. And, you know, offering to people that they are lifting 10, 15, 20 pounds kind of in their day-to-day, and that, you know, we need to make people's training harder than everyday life. So finding ways to build the program and give people confidence in managing their own symptoms and knowing, you know, how their body is moving is so powerful. I do often recommend like the pop-up lifting program if people, you know, don't want to sign up for a whole series of you know, because it's expensive to come to clinic and it takes a lot of time. So there are some at-home programs that are really, really good. But for the most part, it's, yeah, like you said, progressive loading over time, building that confidence, learning how to manage symptoms, and then knowing that you have that organ support with a device can be, you know, so empowering as well.
Mm-hmm. When you talk about pressure management, just for people that may not be familiar with that term, so we're talking about intra-abdominal pressure. Can you explain what is pressure management?
Sure. So basically, intra-abdominal pressure is the pressure from, if you imagine the abdomen, the core muscles around the front, the muscles in the back, your diaphragm on top, and then your pelvic floor muscles on bottom, those muscles all coordinate to manage pressure. So when we cough, our diaphragm descends fast, and the pelvic floor also has to contract to support the pelvic organs. So basically, when we talk about pressure management, it's how we're really looking at, we're looking at a lot of things, but one of the big things is the pelvic floor coming on when it needs to be? How well is it able to support and manage those forces? And then we do also look at, you know, what's going on up above. If someone is doing, especially if, like, say they're weightlifting, you know, are they taking a big breath and bearing down when they, you know, lift the weight? So there are a lot of different strategies for breathing, for, you know, your position. what is happening at the pelvic floor that helps you coordinate all those pieces together, basically to offer your organs the support that they need to be able to do those movements.
Is there a breath strategy that you prefer? I mean, a lot of the sort of retraining philosophies, even if you go back to Julie Wieb's piston, it's about an exhale, blow before you go, exhale just before exertion, sort of as a starting point, then exhaling with exertion. But then there's the opposite, especially in the heavy lifting, where there's often a big, huge breath where and sometimes with weight belts, they're breathing into the belt to create more pressure, which arguably is creating more stability, right? So that's the kind of the part that's tough to hear is like, well, I can't increase pressure because it's bad for my prolapse, but I could potentially be creating more stability if I increase pressure, right? So it's a bit of a dichotomy there.
Yeah, so increased pressure does increase stability for the spine, and that is the whole point. And that is why those weightlifters are wearing those belts, is because they want to maximize their spinal stiffness so that they can lift more weight. There are ways to safely use weight belts, or there are ways to improve safety, I should say, with using weight belts, especially for those who have concerns about, or they do have a pelvic organ prolapse. But there honestly, there is no one breath strategy that works for everyone. We have to test and retest. It depends on the lift, to be honest. It depends on whether or not someone's using a belt, and it depends on the weight. So blow as you go, which is the exhale on exertion, is commonly a great technique for people. Probably not, though, if they want to lift, anywhere near a 1 rep max, if someone is really going for those heavier lifts. So what I like to try is a sub-maximal breath. So take a big breath in and then let some off the top and hold that while they do the lift. And quite often, someone is able to, with a sub-maximal breath, they're able to more effectively contract the pelvic floor and hold it through the lift. And there's a lot of different mechanisms in there, but trying different things, feeling what you feel. And I have people feel themselves externally or even internally sometimes while they're doing different breath strategies with weights, or I will feel while they're doing, overhead lifting a heavy weight, things like that. Because sometimes people bear down when they're breathing out. And holding the breath has kind of been villainized. And doing a Valsalva, which is actually more like clearing your ears, is different than bearing down. So I do try to make sure that people are not bearing down if they're doing a breath hold, and really just looking at what their goals are, what kind of lifting they're doing, especially if they're a higher level athlete.
And how do you make it safer to use a belt?
Yeah, so the easiest way is you don't, when you put on the belt, you don't just tighten the ever-living crap out of it. You have it a little bit looser so that you can at least fit like 2 or 3 fingers into it. And then when you breathe in, you expand into the belt.
That makes sense. In terms of, kind of wrapping up here, but in terms of the research that I've seen, like Lori Forner's done some research with regards to heavy lifting. There's also been the heavy lifting is bad, but running is fine. And, and then comparing the two, and is that really true? And it's not. And it comes down to, as you were mentioning before, it's not the exercise, it's that person's execution of that exercise on that given day at that point in their life with all of the other factors that we have to consider, right? So I don't think we can blanket statement say, and we don't have the longitudinal data, but heavy lifting and what is heavy lifting? Like 80% of 1 rep max, but not many people know what their 1 rep max is, and what's heavy to one person is not heavy to another person, right? So there's all these factors that we do need to consider. But is there a recommendation of, we have some evidence that shows heavy lifting from a occupation, so somebody working, carrying heavy loads every day for hours, 5 days a week, that's an increased risk. So would we want to tailor our programs to be, obviously nobody's going to be training for that many hours, but what would you say there?
Yeah, so I love that you brought up that point because a lot of people do think, oh, heavy lifting is bad, but actually, like, there is a difference between heavy lifting during a workout and heavy lifting occupationally for your work. And there is an increased risk with heavy occupational lifting. So for those individuals, though, I would want to train them to be able to do what they need to do for their work. Look at the strategies that they're using. And listen, I know people want those blanket recommendations. They want the do and the don't list because it's easier. It's easier to say on social media, but, it's just not, I think it's not helpful for people. And people put so many things that are good for our health in that don't category. So, I'm so glad that you're doing this and that we're, helping to get this message out.
Yeah. Bottom line is, we all, especially fitness professionals love the protocol. Tell me how many sets, tell me how many reps and how frequently, the FIT principle, right? Frequency, intensity, time, and type. And I even just general fitness, it's not that easy anymore. It can be easy. And I think a lot of times we complicate it by adding in so many other things to think about. And social media is like every day you probably walk away from social media saying, oh my gosh, I might have gut health problems. I might have bone health challenges. I might have, anyway, it kind of becomes overwhelming. And that's what I mean by kind of clouding and giving us all this extra layer to consider, which is important to know, but really just move your body, move in varied ways, change something, like as Anthony Lowe says, do something different, but change your breath strategy and see how you respond, really.
Yep, absolutely. And, I know that not everyone can seek individualized advice. It's a privilege to be able to access pelvic physio, but and the truth is that, there are people who are probably, working out on the farm who have a stage 3 prolapse and they're not bothered by it versus, someone who has very, mildly symptomatic stage 1 and they are, constantly checking and really, really vigilant. And we do have to look at nervous system health,
yes,
and the whole person when we consider, a plan for someone. But to your point about, where did we go?
So with like, no, there's the FIT principle and there's no real recipe or exact protocol that somebody is going to follow.
Right, exactly. We do overcomplicate it a lot, and it's hard though because there are so many factors to consider. But empowering people to get out and move and not giving them a bunch of don't lists and to get out and do, programs and get moving again is, I think, the most important thing because, we know that the benefits are there. And just to quote Anthony one more time,
I'll send him this episode.
And he's a dear friend of mine. Actually, we're speaking next week at a conference together.
Oh, amazing.
Yeah. But he had some brilliant quote that's, kind of gone viral that is, we're more than our vaginas. Like, it is really important, of course. I'm a crotch crusader and I know you are too. And we want to do our best to help people in this realm of pelvic health. But like, we are more than just that. And, sometimes we need to let people consider like what they want to do with their bodies, what they want to do with their lives. And we're more than just these parts.
I love it. Thank you so much for sharing your wisdom and for the amazing work that you do.
Thank you. Thank you for having me.